Hi, everyone. It's 3:02, so I think we can get started. Thanks for joining CDTRP's Level Up webinar series. My name's Nick Murphy. I'm a postdoctoral fellow with the Departments of Medicine and Philosophy at Western University. But more importantly, I'm a proud CDTRP trainee. I'm going to be facilitating today's webinar. CDTRP is hosted by the University of Alberta, and we respectfully acknowledge that we're located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I'll just add that I'm speaking to you today from the traditional lands of the Anishinaabe, Haudenosaunee, Lenapehouk, and Chinungkton nations. And I encourage you guys to add your land acknowledgement into the chat box. Today, CDTRP is excited to welcome Amina Silva, who will be presenting on the topic, Quality Improvement Tools to Manage Deceased Organ Donation Processes, a Scoping Review. Before I introduce Amina, a couple of housekeeping notes. So today's webinar and discussion are being recorded and will be posted to the CDTRP website and YouTube channel. So during the presentation, we kindly ask that you turn off your cameras and microphones. And then after the presentation, we'll ask you to turn your cameras back on. And if you have a question or comment, to please ask the presenter directly. If you prefer, you can also ask your question anonymously by sending me the question in the chat box, and I'll ask it on your behalf. So now it's my pleasure to introduce Amina Silva. Amina is a CDTRP trainee and a registered nurse who's in the last year of her PhD at Queen's University. Her clinical background is focused on end-of-life care, kidney transplantation, and eye donation processes. And her research program is focused on organ donation processes, end-of-life and survivorship care, and simulation-based educational strategies. Amina is also a research coordinator for the BRIC program, or Studying Burnout and Compassion Fatigue among OTDCs in Canada. She's a research assistant at Queen's University, and she's a simulation facilitator at the University of Ottawa. So welcome, Amina. Please take it away. Thank you.
Thank you very much for such a kindly introduction. Let me just check if you guys can now see my screen. Can you guys?
Yes.
Yes.
Okay, perfect. Thank you very much for that. And I'm super excited to be here in name of the research team I work with to share results from our study, which is entitled Quality Improvement Tools to Manage Deceased Organ Donation Process. And that's results from my scoping review of the literature. And just as a very short acknowledgement, these are the different members of the research team involved in that project. So it is myself, Samantha, Lara, Ken, Sony, Mary McTurfood, Vanessa Silva, and also we have other collaborators that work at doing the data screening and extraction that are acknowledged in the bottom of this slide. And also, just to finish my acknowledgement, I would like to thank CBS and CDTRP for all the support related to the development of this study. And so to start, why exactly did we decide to study quality improvement tools to manage disease organ donation process? So the use of quality improvement tools is a well-established practice by healthcare professionals because it has the potential to improve the quality of care, optimize patient outcomes and safety, as well as decrease costs for the healthcare systems. But even though quality improvement tools, they have been used for a while by healthcare professionals, only more recently, we have been facing a growing awareness from organ donation organizations worldwide in the need of using quality improvement tools to help manage disease organ donation process. And that's mainly because, as all of you know very well, organ donation is a highly specific and complex process. And so there is still a lack of comprehensive evidence on the use of quality improvement tools in disease organ donation. So just to clarify, in that review, we defined quality improvement tools as standalone tools to enhance practice and reduce the risk of errors. And a couple of examples of those tools are flow charts, histograms, scatter diagram, checklists, and many other types of tools that we can have throughout this process. So thinking about all of those concepts I just mentioned to you, our research team come up with the idea of conducting scoping review to further investigate the use of quality improvement tools in the disease nomination process. And the main goal of our review was to collect and summarize the literature on the quality improvement tools that have been developed for the disease organ donation process. And that was both NDD and DCD donation. So just very quickly, a couple of reasons that made our research team to think that this scope review was needed. First of all, because as I mentioned for you, there is no comprehensive evidence related to the use of quality improvement tools in the disease organ donation process, as well as there is no published literature on that topic, no type of literature, either narrative, integrative, or systematic. And also, it is well known that literature reviews with a systematic approach, such as the one we conducted, have the potential to be used to guide policy updates as well as guidelines updates. And so we truly believe that the results from that review can be used to help improving the quality of disease organization process. So because of all of those aspects, we decided to go ahead and conduct that review. So, as all of you know, there are different types of methodologies that we can use when conducting a review. But for that specific research, our research team opted to use a scope review framework from JBI. So the main reason why we decided to go with a scope review is because scope reviews, they do have a systematic approach for searching, but they have a broad scope that allow us to collect both published and unpublished literature. And when we look for quality strategies, we know that most of those occur like in internal organizational process in hospital settings, and they are not usually published in peer-reviewed scientific journals. So really having a type of literature that allow us to collect both published and unpublished literature was deemed as essential for the scope of this study. So related to our inclusion criteria for the studies we investigated, so for participants, we are looking for studies who approach deceased organ donors. And again, that could be NDD or DCD, as well as regardless the age. So adult or pediatric donors, all of them could be included in our review. Our concepts were reports in the development or use of quality improvement tools to help optimize disease organ donation. So the only criteria we had for that is that we needed to have access to the quality improvement tools, because a couple of articles, they mentioned the tool, but they do not have the version of the tool available. So for those articles, we connected with the authors to see if they would be willing to share the tool with us. So the study could be included in our review. And those who shared, then we could include. And also, we did not limit our searching and screening process to any specific type of healthcare setting. So it was really any healthcare setting worldwide, as well as any type of resource. So qualitative, quantitative, case report, any type of study, if it was relevant for the topic, was included. And just a very short timeline. So as some of you may know, when we are conducting a scope review, we do have a series of steps that we need to follow through the process to make sure this review is rigorous and follow all the criteria to be a study of quality. So the first step was to register the title, and we registered the title of our scope review and the JBI databases. So pretty much that's just to make available for the broader community. So if anyone has an idea of conducting a review in a similar topic, they can search in that database and see that we are actually working that review. So that avoids the conduction of duplicated reviews, which is a very important aspect. Following the title registration, we developed a protocol, which is kind of a short paper where we describe all the concepts that we're going to use in the review, the database we're going to search, which search strategies we're going to use, and which data extraction tools we're going to use. And that goes through a peer review publication, so we can make sure that besides all the research team working that protocol, it was also external evaluated to make sure everything is in correct place before we actually start the review. Okay, so after all those steps I just mentioned, we started the actual conduction of the review. So we had the support of a librarian specialist at CBS kindly supported us with that. And this librarian specialist developed this search strategy for different databases. And we use this search strategy for Medline and base, Psychoinfo, SinaHow, Web of Science, academic search via EBSCOhost, as well as we searched for over 50 sites of organ donation organizations around the world to see if we could find more potentially relevant tools to include in a review. So after all the search process was done, all those references they were included on Confidence, which it is an online software for the management of systematic reviews. And in this software, we did a blinded peer review process. So first, all the reference that we found through the search process was screened by at least 2 independent reviews by title and abstract. And then the relevant resources were screened by full test as well by 2 independent reviews. And if we had conflicts about whether or not this reference should be included, we had the input of a third reviewer, which in that case of this study was the senior author who was giving the input about whether or not the article should be included. And for the data extraction, we used the data extraction tool that we developed and pilot test for this study. And I, as the first author, I extracted all the data from all the studies we included, and I had the second reviewer checking the process just to make sure our relevant information was actually extracted, so we're not missing anything from those studies. And for the data analysis, we used an inductive content analysis approach using the categories of disease organ donation as established by Silva and Silva. So pretty much I got all the categories that she divided the disease organ donation process, and then try to categorize the tools we found throughout the searching process in each of those categories. So this is the Prisma flow chart related to the searching process. So as you can see, we actually had a lot of results. So at the beginning of the searching process, we had over 10,000 of references. And out of these 10,000, 251 were deemed as potentially relevant and screened by full test. And 40 references were actually included in that review. So we first conducted the searching process in July of 2021, and then we updated in July of this year, because it was a quite a lot of results that we got. So it took a while to go through all of those results. So we needed to update to make sure we're still getting all the most current and relevant literature. Another interesting aspect of that review, we usually do not conduct quality improvements for scope review because it's not mandatory. You can conduct, but usually it is just not mandatory. But we decided to conduct one for that review, which was in fact a great idea because really helped us to gain more in-depth knowledge related to the existing evidence on that topic. So we used the quality improvement minimal quality criteria set, which is a tool specific to evaluate the quality of the report from quality improvement strategies. And surprisingly, out of the 40 references that we included, we only could access the quality of 9 of them because the other 31 did not report on the methods. So if they do not have the methods, we cannot access the quality of the methods. So the main reasons why they were not reporting the methods is because either we could only find the tool without any context related to the development of the tool, or they were part of major guidelines or manuals, and there was not detail about how they actually come up with the development of the tool. But out of the 9 tools that we could access the quality of the methods, most of them reached the maximum score of 16. Out of 16, only one of those reference had a score of 15, and this still was a pretty good score. So very shortly related to the characteristic of the studies, so most studies were published in English, and just a minority of them were in Portuguese or Spanish. And most studies were from Canada, followed by United States, Brazil, Australia, Switzerland, Italy, the Netherlands, UK, Iran, Ireland, and the United Arab. And most studies were published from 2016 to 2022, and most of them were approaching NDD donation. But the difference between NDD to DCD donation was small. So, and you can see like when you put in the numbers, it may be more than the final number because some of those results were repeated. So as I mentioned to you guys, those are all the categories of the disease organ donation process as established by Silva. So everything you can see in green is the parts that we could actually find tools for this specific process, and the parts in reds because we did not find tools for that. So following this categorization, we divided the results from that review in 8 major categories. So 8 major topics where we could identify quality improvement tools. And those categories were potential donor identification, donor referral, donor risk and assessment, donor management, withdrawal of life-sustaining measures, death determination, organ retrieval, and the overall disease organ donation process. Now we'll be a little bit more specific about each of those parts. And it is a little bit difficult to summarize those findings because even though some of those tools, they have the same approach, they have a very different categorizations inside the tool. So I try to be a little bit more generic. But if you guys have any questions, just let me know. And I'm more than happy to further discuss those results with you guys. So the first category we had was related to the potential donor identification, and that was for both NDD and DCD. And we found 2 reports, which were both from TGLN. So was the same algorithm they were reporting in the adult and pediatric donor manuals. So the report on the acronym called GIFT, which stands for Grave Prognosis, Injured Brain, family-initiated discussions around withdrawal of life-sustaining measures or therapy limited. And if any of those criteria they are met, then the healthcare professional, whether it's from ICU or ER, should contact the TGLN for further assessment. The next category we have is related to donor referral. And we actually only found 1 tool for that part, and it was from Transplant Manitoba, and pretty much was a checklist where the healthcare professional can fill out the information from that potential donor. So the clinical information, medical history, exams that had been performed, and they can use the checklist to forward the information for Transplant Manitoba. So they can make sure all information needed is going to be forwarded in a timely manner. So related to the second part of the results, we have the donor assessment and risk, and we had 6 tools for that part, where 4 tools were for screening and 2 tools were for risk assessment. So that included 2 checklists for donor assessment, and also they have a very interesting app for different modalities of funds. So in that app, the Organ Donation Organization, which if I'm not wrong, it was from the United States, they developed an app for the organ and tissue donation coordinator to use. So they would start doing the screening of the donor and filling out the information, and this information would go from the most generic to the most specific information. And every time they finish filling the information on screen, if the donor meets this eligibility criteria, it goes for the next screen until you finish the screening process. And at the end, it's going to give for you a response about whether or not that donor is actually a potential donor eligible for donation. And beside those tools for screening, we also had 2 flow charts to screen for pre-existing conditions, including hepatitis, skin cancer, and gastrointestinal tumors. The other category that we could find was related to the donor management. So we identified 8 different tools, and overall, even though they were different, they had quite a similar approach. So overall, the main idea of those tools, which included algorithms, checklists, and flow charts, was in supporting the management of respiratory, cardiovascular, endocrine, and renal system of those potential donors. And they also include the specific interventions to manage each of those systems to make sure you can provide the potential better quality of organs for recipients. So even though those tools were different, overall, they had a very, very similar approach. The next category of results that we have is related to withdrawal of life-sustaining measure. And for that part specifically, we found 1 report, which was from a Canadian author. And in this report, they offered a series of different tools that can be used to support the withdrawal of life-sustaining measures. And we included two of those tools, which was a checklist, a very complex checklist, which went from the decision-making process for the withdrawal into the preparation and the death determination. And we also included another document they had, which was a tool template document where the healthcare professional can use this tool to actually register all the parameters and information from the withdrawal process to make sure all of that is registered in details in the medical chart of that patient. And after that, we had the death determination, which was one of the biggest categories that we found. So we had a total of 13 tools, which 12 were specific for NDD, not surprisingly, and one was for both NDD and DCD. But just as a disclaimer that I believe it is important to say related to this category, it's because not all of those tools were specific for organ donation. So a little bit over half of those 12 tools for NDD, they were only for neurological determination of death without the context of disease organ donation. But because this is such an important step of the disease organ donation process, our research team decided to include those as well, as they can be relevant for the process. And those tools include that a mix of algorithms, checklists, flowcharts, and decision map trees. And overall, the focus of those tools was in price-establish and determine the clinical criteria, as well as the confirmatory and instrumental tests that are needed in order to diagnose the death. Second. Here. So the fourth and last part of our results. We had one category which was specific for organ retrieval. And we had 4 tools identified, which were checklists and flow charts. And this category was more focused on the surgical team. So it was more what type of equipment we need for the retrieval process, what procedures we need before, during, and after to make sure we have safety throughout the entire process. And out of those 4 tools, one was specific for liver, one for heart, and the other 2 were generic for any organ retrieval. And the last category we had is the overall organ donation process. So in that category, pretty much we added all the tools that were not specific for only one step of the disease organ donation process. So they included at least 2 or more of the following, which were indication and referral of the donor, determination of death, consent for organ donation, donor screening, donor management, organ evaluation, organ recovery logistics, organ location, family follow-up, and staff follow-up. And some of those tools, they were actually very broad and include almost all of those categories I just read for you guys. But because they were not specific for just one phase, it was difficult to categorize. So we decided to create another section specific for them. So just a couple of implications from that work that I would like to highlight here today, especially considering that we have major stakeholders in organ donation here. So I think there are a couple of points that are important for us as a healthcare professionals and researchers to be involved on. So the first thing is related to the lack of publication from those tools. So we did have a very, very broad research strategy. And we only located 40 tools. And out of those, only 16 were from the searching and the databases. The rest we found throughout the organ donation organization's websites worldwide. So that really shows there is a huge lack on the publications of those tools, because let's be honest, for sure, there are not only 40 tools in disease organ donations available worldwide. The second thing is related to the lack of evidence regarding the methods used. So as I mentioned for you guys, only 9 reference reported on the methods. And so it makes very difficult to access the quality of that literature if we don't really know how those tools were developed. The last part relates to the lack of testing of those tools. So only 2 articles actually mentioned the process of testing. The other ones did not mention any aspect. So we don't know if those tools were pilot tested or somehow tested before the full implementation. A a couple of conclusions from that work. So we could map the international literature on the use of quality improvement tools to manage disease organization process and different phases involved. Unfortunately, despite the evidence from the effectivenesses of quality improvement tools in other healthcare settings, we could not actually locate evidence that could let us claim that quality improvement tools are efficient to manage disease organization process. And the main reasons for that is because of the lack in the report of methods and testing of those tools. So I really brought here a couple of aspects of potential directions that I really think we as major stakeholders working in disease organization, we need to be aware when we are working quality improvement tools and maybe even like when conducting further studies. So the first thing it is related to the need of improved knowledge translation strategies. So as I mentioned, only 40 articles was a very low number considering the such broad search strategies we had. So I do believe there are much more that was not found throughout the searching process. So that really shows for us that we need to work more on the knowledge translation. So it's not only developing those tools, but making that available for the broader community. And even when we look for the knowledge translation gap, so it is well known nowadays that it takes in average 17 years from publishing a certain knowledge to have it incorporated in practice. So if we're not even publishing this knowledge translation gap is going to be even larger. The next thing is important to consider is integrate efforts. So when you look for those tools, a lot of them have a very similar approach. And even like when you look for Canada, because the healthcare settings, they work in a provincial manner, a lot of organizations, they had very similar tools. And of course, the tools are going to differ based on the specificities of each province, but maybe a couple of those efforts could be made in integration to try to provide a more rigorous process and maybe even work more in the testing of those tools. And again, it is very important that we test the effectiveness of those tools. Because if we are only developing those tools and we're not testing, is that really improving the healthcare process or is just adding an extra burden in those healthcare professionals? Because we are giving more work for them and we don't even know if that's actually effective, right? So we give checklists, flow charts, and we say that's going to improve. But if we do not test, if we do not make changes related to the feasibility, we do not know if that's actually making the process better or not. And the last thing that's extremely important as well, and we can see in the literature, there's a huge lack of report on that, is educational strategies for healthcare professionals on how to use those tools. And even a couple of the studies that I was looking during the searching process that were not relevant to be included, but that was just by curiosity screening through the papers. Some healthcare professionals, they say they do not like quality improvement tools because that is just an extra burden because the manager or the person responsible for managing the unit just give for them the tool and say they need to use, but they don't know how to use. They don't know what is the main purpose behind of using those tools. They were not involved in the process of creating. So really, if you wanted the healthcare professionals to be really engaged on those quality improvement strategies and using those quality improvement tools, they need to be engaged in the development and implementation process as well. So that can truly help increasing the feasibility and potentially even efficiency of those tools. So those are just a couple of the reference that we had throughout that. And now I'd like to open for any discussion related to any of the topics we covered today.
Wow, Amina, thank you for that incredible presentation. You talked about it very calmly, but it looks like it was a tremendous amount of work that must have taken a lot of time. So congratulations on that work.
Thank you.
Yeah, so now that we're done, I'll just ask that you turn your cameras back on if you like. And if you have a question, just raise your hand and I can call on you and we'll ask you to ask the question of Amina directly. Or if you prefer, you can put the question in the chat box and I'll ask it, or you can message me privately and I can ask the question on your behalf. I guess I could just get us started with a question. It is interesting that only you were able to assess only 9 of the studies for quality of methods. And I guess my question is just about why it is that so few of these quality improvement tools have methods in them. Is that just a feature of what the tool is, or does it have something to do with a lack of evidence base? So I'm thinking particularly of, for example, organ donor management quality assessment tools, where the literature supporting many of the interventions might be not that well developed. Can you comment on that?
Yeah, sure. So, to be quite honest, I don't think it is related to the lack of rigor involved in the development of those tools. It's more where we could find those tools. So, as I mentioned, out of the 40 reference, only 16 of them were from the searching processing databases. The other ones were measured from organ donation organization websites. And they do not really report on the methods they use. They only make the tool available online so people can have access to that, which it is okay if you look for the context of internal process for healthcare settings. But for you as an external person from that organization to be able to use that tool, you really need to have more information. Because of course, we believe they use that best practice evidence and guidelines, but we will need to know which ones they use that. How was the methodology chosen to develop those quality improvement tools? Because without this information, it is very difficult to understand what is the actual quality of those tools. Even though, like, we believe those tools, considering the organ donation organizations that we retrieved the data from, we believe those tools they were based on best practice guidelines. But without that information, we cannot claim that. So it's still like a gap in the literature, because we cannot say how good or not good those tools were, or giving more specific directions.
Right, that makes sense. Thank you. Vanessa?
Yeah, just to build up on the question that Nick asked, Amina, would you just comment on how the lack of quality assessment would impact the development of future tools or guidelines, just because I think it's important information to share. Thank you.
Absolutely. Yeah, and that actually impacted our plans, next steps for that research, because our main idea when we started was to get those tools and perhaps do some testing to create a set of quality improvement tools for organ donation process. But because we do not have the report on the methods used, we cannot actually use those tools, because we don't know which process was followed, which guidelines were used, and if there was any testing for feasibility. So that directly impacted the use of those tools. So probably, so let's suppose if TGLN, and that's just an example, not mention anything specific, they have a tool in their website. That tool is good for TGLN to use, and that was the main purpose of them developing that tool. But you, as an external process, as an external person to that organization, very unlikely you're going to be able to use that tool, because you don't know which steps were followed, if that was national guidelines, or if it was specific to Ontario, or if it was specific to GLN. So really, this lack of report limits the applicability of all of those tools. And that, again, huge gap in the literature. So I was very happy that we decided to conduct the quality improvement assessment, because usually we do not do that, but really helped us to understand much better how is the current body of literature on quality improvement tools and disease organ donation.
That's great. I suppose I have another question as well, unless anyone either wants to jump ahead of me. You mentioned that uptake of quality improvement tools is an issue. I think you mentioned that some healthcare providers don't like using them for a number of reasons. I know it wasn't the focus of the review itself, but did you incidentally come across any studies on how to improve uptake, and if so, how might organ donation organizations use that information to improve uptake?
Absolutely, that's actually a great question. So we did not come up through those articles in the searching process, but while we were writing the manuscript, we searched for more evidence to improve the discussion. And the main aspect they mentioned that can improving the use of those quality improvement tools, and that was not specific to organ donation process, but in other healthcare settings, is to engage those healthcare professionals in the process. So if you are trying to build a tool to be used, for example, for ICU nurses, you need to go for ICU nurses and ask their input on the tool you are developing. If you want a pilot test, you need to go for those nurses to pilot test and make sure it works for them. Because it is very, and especially like when you look for disease organ donation, it's such a highly complex process. And for people who are not, even though if you work in organ donation, but if you're not an OTDC and you are developing a tool for an OTDC, you are not going to be able to do that effectively if you do not have the OTDC supporting your process. So we always try to engage more those healthcare professionals in the development and implementation, because if they feel they are part of the process, they're going to be more likely to understand the importance and to be committed with the cause and using those tools and understanding the purpose of the tools, right? Because if you're just giving tools for healthcare professionals saying use that, is going to improve, but you're not giving explanation. How is that going to help? Because like at this point, I'm just like full of work to do, and that's just one thing to add to that. So
yeah, that's a great point and suggestion. You know, if you're making it for a user, you need to include the user in its development. Katie, you have a question?
Hi, Amina. It's nice to see you again. Great talk. Congrats on your publication too. That's exciting. How would you, my question, I might be a naive question and I'm sorry if it is, but how would you assess a QI tool like in practice, like in the real world? Like how would that happen?
So to access the QA tool that's already in practice would be doing testing for feasibility. So for example, you need to see which types of outcomes you wanted to achieve and find metrics to measure that. So for example, if you develop a tool that's related to family referral or family conversation or donor referral, and you know that only 10% of the patients who have neurological determination of death have been referral, and you develop this tool. So you need to access this metric after implementing the tool. So those metrics improve it or did not improve it. If they did not, so maybe the aspects you approached in the tool, they were not the gaps that you needed to work on. So those metrics are very important. And again, doing the pilot testing. So every time you develop a tool, before you're trying to implement that, you should do a pilot. So pretty much take a small sample of patients or healthcare professional and do a testing for that. So it is this tool feasible? Because sometimes it may be a pretty good tool, but it is not feasible for the way the organization works. So you need to make change to make sure it is feasible for healthcare professionals to use that, and they are aware on how to use those. So then you can evaluate the metrics related to the tool you developed. If that makes sense. If not, just let me know.
No, it makes super sense. Thank you. Do you think like, do people do these pilots and they just probably maybe don't report on them? So there's not, that information is not available to the public, or you don't think so?
To be quite honest, I don't think those pilots are truly made in practice. So I think like they may do the pilot within those person who created, but I'm not sure if they do with the healthcare professionals who are actually using. And I'm using that to say, even based on my previous experience. So every time they had a quality improvement tool developed in the hospital I work at, this team who developed would come with this tool and just give to us and like, okay, so from now on you have this checklist, use it. And you were like, okay, so I need to use that. And it's like, oh my gosh, that's so annoying. One more thing for me to do. And yeah, I think Vanessa raised the hand and I'm pretty sure she has a good point because she has experience in developing those tools as well. So maybe another side.
Yeah, just to add to that, Amina, usually when we're talking about quality improvement tools, they are not research-based tools normally. So usually we have some specific analysis that we do in an error in the process or things like that, that you're trying to fix. So you identify everything that is wrong and you try to fix that with a quality improvement tool. And that process is not recorded as research normally. It is recorded as a document within the hospital, and then you create a tool that is implemented, like a form, a checklist, etc. So normally those things don't get published, and that's the huge gap with the study that Amina led, because we need to have that publicly available so we can have some common sense on what works for organization and how we can improve things worldwide. So if everyone starts doing like quality improvement tools here and there, and we don't share, then we cannot never improve things in a common sense. So that leads to problems like lack of commonalities in terminologies. So we have different things being called effective donors, for example. So those are some of the minor things that can happen when you don't share your results of quality improvement tools or anything like that. So what we're trying to do as a next step is try to evaluate some of the tools that makes more sense and pilot test and develop an actual research out of the quality improvement tools, and then that would be publicly available and people could download and test and use. So that would be a next step for this study now that we don't have all the evidence that it takes to develop an actual manual or protocol or anything like that to be publicly available.
Yeah, and just building on what Vanessa said, which is very important, is because it is understandable that since you are developing quality improvement strategies inside an organization that usually do not make that available. But the only problem with that is because you have a lot of different organizations working the same strategies separated. So you have a lot of small efforts towards achieving something. But if we could make that public available and we could integrate those efforts, for sure, we could develop tools much more comprehensive and with testing and feasibility and even potentially more efficient. So it is understandable those organizations are working separated, but in some aspects, they could definitely come together to work in developing something that's more comprehensive. And of course, adapted for each setting because those settings are going to have different internal process to follow through.
Yeah, that's great. And it almost sounds like there'd be a place for a cluster randomized controlled trial design for assessing these quality improvement tools across institutions. Jillian?
Mm-hmm. Thanks. This was really interesting presentation as one of those people who's constantly updating those tools when error accidents happen. Just listening to kind of the questions we had so far, something that I was wondering is, for those ones that you described as having methods and procedures and the ones that were published, were they primarily changes and updates to existing QI tools, or were they mostly new implementations?
So our studies from the literature, not all, I think only 2 were adaptation, all the others were new tools developed. And that is also a very interesting point because a lot of times, and that's not only for quality improvement tools, educational strategies as well in overall, like they are developed, but they are not updated. So once they decide it's not working anymore, they just come up with new things instead of trying to work on the ones they had to improve. And sometimes because you are not really going back and seeing like why that's not working, you are not being able to improve in the upcoming strategy. So that's such an important point. Like we need to work on updating those tools and going back and see like what process we follow. So did we have improvement in the metrics? We did not. Why is that? You know, to try to work in making tools better and not only like creating new tools. That's a great point, Julian. Thank you for bringing that up.
Towards the end of your presentation, you sort of had these 4 categories of things that should be done. And it seems just from our conversation now that one of the problems here is this dispersion of people working in different silos. So you have sort of organ donation organizations, you have hospitals, and you have hospital networks, and then just researchers, I imagine, working on these things. And it seems like all of the things for steps forward suggest that some sort of centralized work needs to come together to basically put everyone in communication, like a sort of QI CDTRP. And I'm just wondering sort of how do you think that communication network can be got going? And ultimately, who's responsible? Who should take the lead to undertake the things you suggest?
I think it really depends on how would be aimed to have those collaborations. So, for example, if was within a country such as Canada, would be much easier to have like a national network where people could come together. And again, would not say it doesn't need to be something like, okay, so let's develop one tool and apply to all the provinces. That's not going to work because the process, the internal process, are going to be different. That leads to see like what strategies are going on and how I can adapt to the tool you develop for my setting and how that can be better than the tool you develop. And then you can maybe even update it based on the updates I made online. I'm not sure if that makes sense, but really like this collaboration of coming together and sharing what people are working on. Even though people, if they don't want to publish those tools, but at least have a place where they can share so people know like, okay, so this organization developed these tools to improve the referral of donors and that worked for them. So let me see if I can do something similar. Because if you don't have that available, everyone is starting from the zero. So you are having a lot of tools that they started from zero instead of being built up in other tools, which could definitely improve the process because it's much easier if you build from something than from the zero, because you know pretty much a little bit at least from what works and do not works. So yeah, I actually love the idea of having a network for that, only for sharing those tools, like, but more internal, not only quality improvement and overall. We do have organizations for that, but then it makes more difficult, right? Because if it is just healthcare settings in generic, it's going to be such a broad approach, and I think collaboration will be more difficult.
Thanks. That makes a lot of sense. Katie, Manuel, you're on it, right?
I really like that idea though. Like I was
Yeah.
trying to think, one of my questions was going to be like, how are you going to convince people that they need to work together? But if you go to them and say, we want to like find people from, I don't know, all of the different organizations and invite them to sit in something.
Yeah. And especially, and that was something interesting. I don't remember exactly the tools, but like some of the tools across the Canadian organ donation organization, they are very similar. Like you can see they follow different steps, different process, but like the organ donation process, it still works a little bit kind of similar, the steps you follow through. So, you know, maybe taking some of those and working together to have more even consistency, right? Because even though the organ donation organizations, they work separated, they also work among them, right? Because like some organizations, they do not have a retrieval for all organs, so they need to share and they go Ontario, go to Alberta or whatever. So really has those different settings. So they are kind of interconnected as well. So having like a more consistent process perhaps could be something useful.
Austin, did you have a question or comment?
Yeah, sorry about that. Hi, everybody. These tools we're talking about, just thinking when I was listening to everybody, if myself as a deceased donor recipient, wouldn't it be great for somebody like me to have access to a tool like that? Or somebody in, you know, that's capable in my position to work with a team to, I mean, I never heard of a tool for, you know, like quality, you put in quality parameters and do measurements. I understand the philosophy, absolutely. But the, I could use one like for putting in your own input. You know, you say, okay, like every day you get up and you say, okay, what am I doing, which is right? You know, what am I consuming, which is what a lot of people do anyway, just for their own benefit. But you incorporate that into tools that are along with your medical history. It only makes sense to have a better, the more data you get in there, the more valuable your input is. That's what My philosophy always was. But the as a patient, I think it's you have to get people, and I'm sure it's going in that direction, but people with the that have experienced the actual experience itself to give the I'm not going to say it's going to be an objective input, because it's not. It's going to be a from that person's perspective, and everyone is different, so it's going to be difficult to put that into research, but I don't know how you're going to do it. But I mean, I sure could use a QI tool like that. It reminds me of a movie of I can't remember who played with, but he fell in love with his artificial intelligence. That was years ago.
And that's
Sorry.
actually,
Okay.
no problem. And that's actually a great point, because there is also this perspective that we also need to, depending on the focus of the tool you are developing, you need to have patients engaged as well, right? So for example, we know that one of the major reasons for low rates of organ donation, it is family refusal. So really, if you are trying to develop a tool to help improving the approach with that family members, you need to have those family members involved as well, because you can approach from the healthcare perspective, but if that involves the patient perspective, they may want it to be involved in that, give their input, and even like have access to those tools, as Austin just mentioned. Do you want to say something, Vanessa, to add on that?
Yeah, just to add on that, that came up in one of the scoping review that I did for my PhD, where I investigated various aspects, success aspects for organ donation programs, and there was a lack of research on patient experiences and patient satisfaction with organ donation processes. So yes, I agree with Austin that it's very important to include patients' perspectives into that, because sometimes we're very concerned with the timeline that we have to conduct the whole organ donation process. It is a very fast-paced scenario. You have the referral, and your end game is to finalize the process with organ retrieval for the recipients. And the OTDCs, the organ and tissue donor coordinators, they are concerned with the families throughout the process. So it is an added thing, but sometimes our perspective of what we're focusing on, supporting the families, may not be exactly what the families are actually needing in that moment. So I agree that adding that perspective to the development of future QI tools would be key. So thanks, Austin, for bringing that in, and thank you, Linda, also for your comment on the chat.
Yeah, I was just going to read out Linda's comment there in response to what Austin had to say. So Linda says, thank you for this work. Research and evidence-based practice at work. Consistency and well-communicated rationale across jurisdictions would be helpful for families to understand the process. That's a really good point. Did you want to comment on that, Amina?
No, I think it is. I think it is truly important to have those different parts involved, because sometimes we always create strategies. And now I'm not just talking about quality improvement tools. I'm talking about healthcare strategies in overall. Sometimes you create it and always come from top to the bottom, right? So someone to develop, to implementing, but you are developing something to be implemented among other group of people, which may involve other healthcare professionals or family members. And we usually, like as a healthcare professional, we do that. We don't give the chance for people to give inputs and the things that are actually going to impact them. And I think that's such an important aspect that makes the implementation process so more difficult. So therefore, I truly believe that's one of the reasons why we have so many strategies that are not actually bringing outcomes as good as it could be, because we need to have more engagements, and we literally need to have more knowledge translation strategies for sure. That's, I think it is another important aspect. And knowledge translation, not only for healthcare professionals, but for family members as well, to know what is out there and how this process works, because they are part of that, right? So they truly should be able to have access to this information.
Yeah. Yeah, thank you. So we're just about out of time. If nobody else has any other questions, I'll just ask one last one, and then we'll say goodbye. I guess it's just, where do you plan to go from here with this research program? What's next?
Yeah,
Or from a
sure. So
holiday,
that's
well-earned holiday.
that's a great question. So what we're doing now, we are in process of trying to publish that article, and from that, we wanted to try to come up with some of those tools that we found that could be potentially further developed. And the main intent of this work was really, we wanted to try to develop a set of quality improvement tools that can be used to guide how the organ donation process. So for sure, if we develop this set, the set's not going to work in the same way, for example, in Manitoba and in TGLN, but that's going to be a good underpinning for people to work from there and adapt it to their location. So we need to try to move forward with a more comprehensive work in that area, because unfortunately, from this scope review, we cannot say quality improvement tools are effective for disease organ donation, because we do not found this evidence, even though we truly believe so. I'm pretty sure they are effective and they generate improvements in outcomes and metrics. But without accessing this information, without having those studies published, the literature is limited. And so it is the involvement for future researchers, because if you're going to research in an area that has so many gaps, it gets much more difficult. So really, we need to work to improve that, not only in healthcare settings, but also in research and even academia, like on how to further improve those practices, because quality improvement tools, they have such a huge potential. They can improve outcomes, improve safety, reduce costs. We just need to be more involved, or maybe more clear reports.
Great. Well, yeah, no, we look forward to seeing more of your work and what comes out of this. And thank you so much for that presentation and for sharing your findings in this important project. Thanks as well to everyone for comments and questions. And a special thanks to Amina on behalf of CDTRP for coming today. So if anybody has any additional questions for Amina, you can feel free to contact Manuel, and he'll forward them to her. His email is mescoto@cdtrp.ca, and I think Manuel can pop it into the chat box for us. A reminder that CDTRP's webinar series continues next week. And on Monday, we're going to be having the topic, Exploring Ethical Considerations of Direct Contact in Pediatric Organ Transplantation, a Qualitative Study. So that looks to be very interesting, and you can register at cdtrp.ca. Thanks to everybody for coming, and thanks again, Amina, and take care.